Welcome back,
Hey,
everyone, to the Prescribing for Pregnancy. I'd like to introduce you to Joyce Popoola, who has come in from St George's in Tooting. She's a consultant nephrologist, and she's going to give us a presentation on understanding and managing urinary tract infection in pregnancy. Thanks, Joyce.
thank you. So can you see me
Can see you and can hear you. So I'm
and you
assuming
can
you're
hear me?
just about to share your slides.
Yeah, but I'm not going to use so much in the way of slides here. I think when I found out all the technical technology issues, I thought, let me have a backup plan here. So I'm more going to talk to you, and I'm hoping that we can make this sort of like an interactive process as opposed to me just blabbing on and showing you slides and slides of things. But you don't get out of slides because I am going to send you some handouts and some key slides at the end of this presentation. So I just wanted to show you the front page of the slides just so that you're focused on what we're talking about. And if I can't do this, I'll leave it. Okay, you know what? I'm going to leave this because it's not actually dependent on the slides. And yeah, so just so that you're all aware, what we're talking about is we're talking about the management of urinary tract infections, but then putting in the nuance for when it comes to kidney disease. So I think, first of all, we just need to take a step back and sort of like just reflect on the sort of like the scale of this problem. So, first of all, it's fair to say that urinary tract infections are among the commonest infections. I don't think anyone's going to dispute that. It's also fair to say that in pregnancy, that the infections tend to be more common. So let's take another step back and then let's think about, so what infections are we talking about? So when it comes to urinary tract infections, it actually covers about four main types of infections. So you've got cystitis, which is actually inflammation or infection that's located in the bladder. You've got urethritis, which is the urethra, that's the lower part that just enters, and you can all remember your anatomy. And then you've got pyelonephritis. And once we're getting onto pyelonephritis, we're talking about more serious infections. And the key here is that usually it didn't start as pyelonephritis, that's infection that has actually affected the kidneys. It started lower down and then tracked up, either because that person was overwhelmingly immunosuppressed, and so it was a very rapid progression, or it might be because perhaps the patient had an infection in the lower tract for a prolonged period that wasn't dealt with in a timely fashion, and it therefore progressed and ended up as pyelonephritis. And it's one of the conditions that we really want to prevent. And as a nephrologist, one of the reasons why I really get upset seeing patients with pyelonephritis is because I know that this can lead on to actually kidney failure. And then the other infections, so we've talked about cystitis, urethritis, and pyelonephritis. But the other one, which we often forget about, is vaginitis. We still think of that as part of the urinary tract when it comes to infection. And then the other thing that we need to think about is overwhelming sepsis or septicemia, which should be the never, never go area for a urinary tract infection developing into septicemia. And then we'll just touch on two things. On the one hand, when we're talking about pyelonephritis, remember when it's got to the kidneys, we talk about acute and chronic. And once again, we absolutely hate it when we get to the point of having patients with chronic pyelonephritis, because often this is because they've had acute pyelonephritis and we've just not treated it. And it might be we've not treated it adequately, or we've treated it with the wrong antibiotics or used too short a duration of antibiotics for this individual. So we'll get onto that a bit more later. But I hope everyone in the meeting is now aware of the various types of infections that we're talking about. I'm then going to go on to why is it that pregnancy is a peculiar situation where we tend to get more infections. Well, funny enough, I can see majority of us here are females. So we know what happens to the body when we're pregnant. In the first instance, we slow down completely. In the second instance, lots of things are getting bigger. And in the third instance, our anatomy is changing significantly from what it is when we're not pregnant. So let's go to the anatomy first of all. So you've got the hormonal changes that take place, and this is one of the reasons why infections are actually more common from the 6th week up until the 24th week. And then the other period of pregnancy when they get more common, but not quite as common as that initial period I mentioned, is in the last trimester. And then they're less common. And the reason for that is because, well, the anatomy is more or less the same as usual in those first, say, 6 weeks. So what's going on in that 6 to 24 weeks that makes things so different? It's largely as a result of the hormonal changes. So what's happening? We're getting that imbalance of the estrogen being replaced with more progesterone. And what does progesterone cause? Well, it causes all the tissues to become lax and dilated. So that's on the one hand. So it even affects the urinary tract in that fashion. And because it's dilated, you're more likely to have issues around stasis. So let's think about that. So hormonal changes are going to cause stasis, which cause us to be more prone to urine infections in pregnancy. So what else is going on? Hey, it doesn't take a genius to guess. It's that gravid uterus that just keeps getting bigger and bigger. In the first instance, urine infections are more common in females than males anyway. And the reason for that is just because men, they've got that protection of the long urethra, whereas women, we've got very short urethras. So anything from the outside can easily come on the inside. Now, the other little thing is the fact that the urethra and the vagina are very close in actual fact to the where we pass our feces. And so unfortunately, there's that constant contact between the three orifices that just makes women more prone to infections anyway. Then on top of that, the shorter urethra. And so that's also the case in pregnancy. But on top of that, there's a new anatomical change that takes place. The uterus gets bigger and bigger. And remember, you've got the urethra in the front, the uterus in the middle, and then the anal tract at the back, with the uterus just getting bigger and bigger. And so what has to give? It's the bladder. It gets pushed in a way such that some of the natural mechanisms in place to prevent that straight reflux of contaminations going into the bladder are lost, because increasingly the bladder straightens out to almost align with the urethra. And most infections actually come from external going in. And that's why I guess it doesn't take any geniuses to guess what are the most common organisms. The top commonest organism is E. coli. And we all know that that's one of the commonest organisms in the gut and certainly in feces. So if you can remember that E. coli is actually going to form about 70 to 80% of the infections. And then you'll wonder, so what infection comes next? You've still got some other gram-negative organisms like Klebsiella. Why is it important for us to have an idea of these organisms? Because we need to treat them, and when we're treating them, we need to make sure we're treating with the right antibiotic. So if you think of it, the commonest organism for most of us is going to be E. coli, and then Enterococcus, which are gut organisms. But you've also got Klebsiella. So those are the commonest organisms. But then you've got the other organisms that commonly cause urinary tract infections, which are often from the skin. And that's where you have things like Staphylococcus and then, yes, Streptococcus, which are usually from the skin flora. And so, what have we talked about so far? It's not me just rabbiting on, but we've actually talked specifically about the fact that urine infections are more common in females, but even more common in the context of pregnancy. And so let's put some percentages on that. So what's the percent of urinary tract infections in women in pregnancy? It's actually about 8% of women that get pregnant are going to have a urinary tract infection. And that's quite a high number. It's almost 10% of women are without a shadow of doubt going to get an infection. And I want you to remember that urinary tract infections are probably the commonest and most significant infection that women develop in pregnancy. So we've got that on the one hand. And then we've got the scenario. So we're getting into terminology now. So what are we talking about when we talk about recurrent infections? We're talking about infections that occur repeatedly. So at least having more than 2 infections in a relatively short period of time. Outside of pregnancy, we talk about recurrent infections if a woman gets an urinary tract infection, a distinct separate episode of infection, at least 3 times in a year. Now, in pregnancy, it's different because remember, for most people, pregnancy lasts about 9 months. So then we're talking about if a woman gets a urinary tract infection twice or more, then we consider that to be a recurrent infection. So we talked about that terminology of recurrent infection. But I will say that this shouldn't be confused with an infection that actually just hasn't really properly cleared. And so by that token, we're talking about incompletely eradicated infections. That's one terminology we can use. Or persistent infection. So here we're talking about where we may have partially treated an infection, haven't been sure that it's cleared, and it may appear to maybe someone outside that this individual is having recurrent infections, but they're not. It's either incompletely cured or a persistent infection, and potential reasons other than what I've mentioned could be maybe using the wrong antibiotic. And so let's hone down on that a little bit, because it's one of the commonest problems that we see, not only in pregnancy, but even in the general population when it comes to urinary tract infection. So how should we go about managing an infection? And we'll go into a case scenario here. A lady books into pregnancy late. She books in at 28 weeks. And she mentions that her GP has been repeatedly treating her for urinary tract infections. And she might tell you that I've had 7, 8 urinary tract infections. But then it's down to us as midwives, as nursing team members, as medical doctors, whoever we are, to actually ask the right questions. And so in this kind of scenario, we need to ask from that woman is, how were your urinary tract infections diagnosed? Which is key in urinary tract infections. The questions we need to be asking are, what were your symptoms? Now, symptoms in urinary tract infections can be very variable. But before we get to the point of symptoms, we need to build a case for that individual woman. So we need to think, okay, she's pregnant, so she's more prone to getting urinary tract infections. But what else is in her history that could make her more prone? So we need to find out about her past medical history, which needs to find out whether she's got any congenital malformations. So women who've got congenital malformations of the urinary tract are going to be more prone to urinary tract infections. So a history of reflux, maybe an abnormally positioned kidney, maybe duplex urinary tract. There are lots of malformations, and these malformations will be unique and distinct in individual women, but it's down to us to get that history, which we can get from their GP records, their booking information, or we can actually take that history ourselves from the women. And sometimes it's useful having mothers in consultations, particularly for younger women. But congenital malformations are a common association, making women more prone to getting urinary tract infections. Key part of history. Another thing we need to ask about is about medications they're on. Now, some women might be on agents which would lead to them having a suppressed immune system. And I'll just give you a few examples, like in the renal world, say somebody who's got lupus, for instance, will have a suppressed immune system. It could be someone with a transplant, for instance, somebody with rheumatoid disease. They will have a suppressed immune system. And then you've got some other disease processes that we need to think about. Somebody with sickle cell disease, for instance, will be more prone to developing urinary tract infections. Another scenario that is commonly associated with urinary tract infections is women who have stones in the urinary tract. Other conditions could be women who've got ulcerative colitis or other bowel conditions that predispose them to diarrhea. Now, we can't exhaust the other background aspects of background medical history that could predispose you into urinary tract infections, but it's important to have an antennae up and to ask the right questions. Apart from what I've mentioned, a very simple scenario of women who are more likely to have urinary tract infections is, for instance, women who had urinary tract infections outside of pregnancies. So this is a key question to make sure we ask. So in other words, history in the context of urinary tract infection, their management, their investigations is absolutely essential. Now at St. George's, we've got into the habit of actually siloing our women into women who are high risk, women who are medium risk, and women who are what we describe as low risk, even if they've developed one urinary tract infection. And what we have found is that women who are high risk these women do not do well in just ad hoc clinics where we don't have our midwives having the knowledge and awareness that urinary tract infections are extremely important. I'm going to tell you why urinary tract infections are very important before we go into sort of like investigation and management. Urinary tract infections are extremely important for the reason that if women get repeated infections, I almost feel like asking you questions and asking some of you to shout out or put in the chat what happens to women who get repeated infections as to why we don't like them. First of all, there's the morbidity and the general feeling unwell that you get when you've got urinary tract infections. They're extremely uncomfortable. And if they progress to pyelonephritis, well, the women have to sometimes be admitted, taking them away from their family, taking them away from enjoying the process of their pregnancy. But also, if they get these infections, then unfortunately they have to have treatment as well. And once people have to have treatment for infections, then we have to think about what are the side effects of these antibiotics or the treatment that we're giving to them. So there's that. And those are things that can affect any woman who is having a urinary tract infection. But then let's get into some specific things as to why in pregnancy we do not want women having repeated, recurrent, or even any urinary tract infections at all. First of all, if we think about it, the same milieu that the pregnant woman has is the same milieu that they're providing to their developing fetus. Remember, a lot of the development of organs, tissues are taking place, particularly in that first 6 to 24 weeks. So infections can lead to the fetus not developing properly. So poor development, but also issues like small fordate infants due to failure to thrive. But apart from that, because the milieu and the environment is uncomfortable, it could actually predispose the woman to having to deliver early. So, in other words, premature delivery. So, infections can lead to failure to thrive, to small fordate infants, to premature delivery. And we know that when you have premature delivery, you can actually end up with more instrumental delivery and an increased incidence of the need for cesarean sections. But also, by the same token, remember sometimes these infections can end up as being septicemia or a systemic infection. And so the infant can end up with these infections themselves, which can manifest as septicemia within that infant, even meningitis. And we all know about the dangers of streptococcus in the urinary tract and delivery, what that can cause, and the effect on the eyes and other things. So infections are not something to be poo-pooed at. Yes, they're very common. Yes, they can be benign, but yes, they can also become malignant, having profound impact on both the mother, the infant, and the entire family. But also remember the load that they put on the services. And we all know how overrun we are within the NHS. So let's think a little bit now about the symptoms that enable us to detect. So remember, it can be urethritis, cystitis, vaginitis, pyelonephritis, or septicemia or overwhelming sepsis. So how is it that this woman is going to present? Sometimes she doesn't actually have symptoms in the urinary tract. And actually a dangerous situation, particularly women who maybe have had recurrent infections before. Sometimes they're not even aware that they've got these infections. And that is what often leads on to them developing chronic pyelonephritis. Or it might be that actually they just think the symptoms they're having are not infection and that they happen to all women in pregnancy. And that's one of the dangers of social media. And that is one of the reasons why, as midwives, you have such an important role. Because the key way of preventing these urinary tract infections is actually education, education, education. And so we're going to go through together some of the symptoms that may seem a bit atypical. So there's the completely asymptomatic. There's also just that feeling of general tiredness, general malaise, just non-specific unwellness. Now let's think about some of the specific symptoms within the urinary tract. A lot of people will be shouting out dysuria, pain when you pass urine. Actually, that's quite a late symptom. And by the time that's happening, it's because there's irritation within the urinary tract. And so a more common symptom is actually frequency, just that I find that I have to go to toilet very frequently. And a little trick to knowing the difference between that frequency that comes with later pregnancy and with urinary tract infection is that often a time with the frequency with infections, its frequency is such that they don't actually feel relieved when they pass the urine. It can be associated with a sensation of discomfort, which it might be like a pricking sensation, or it might be full-blown dysuria, like a burning sensation when they pass urine. But the trick here is that it's actually not relieved, and the next time they pass urine, they'll still feel that same sensation. So dysuria, frequency, burning sensation, malaise. And then we come to the pain. Sometimes, yes, especially with cystitis. But remember, there is a nuance I want to bring out here. Cystitis is not actually always infection. Sometimes it's as a result of inflammation for whatever reason. And we'll touch on this when we talk about some of the preventative maneuvers that women can adopt to prevent urinary tract infections. So, pain, especially over the bladder area. Now, by the time a woman is complaining about pain where the kidneys are, and a lot of women don't know where their kidneys are, so it's often a good idea to educate them that they're in the loin region. So by the time they're getting pain in that area, often it's because they've actually got pyelonephritis. So we want to detect those urinary tract infections before they get to that point. So yes, you have got symptoms. Symptoms, symptoms, symptoms. Let's go by the symptoms. And then we'll talk a little bit about how to diagnose these urinary tract infections. So, in a way, it goes with, is it only the women with the symptoms of the fever, the malaise, or the pain, or the frequency, the dysuria that we should be investigating? Well, actually not. Actually, on booking, every woman deserves to have at least a urinalysis. Cheap, cheerful, can be done even in the home setting. And what is it that we're looking for on urinalysis? We're looking for abnormalities, but there are two key ones that go with urinary tract infections. And in fact, that reminds me, there's another condition, a systemic illness, and that's diabetes. Women with diabetes are also more prone to urinary tract infections. So when it comes to urine infections and your dipstick, You're not looking for the protein necessarily, although it can be associated. You're not looking for the glucose necessarily, although it can be associated. And women who have these in their urine may be more prone to developing urinary tract infections. But the key things you're looking for, and I want us all to remember this, is you're looking for the presence of leukocytes. And then you'll say, is leukocytes, does that mean that a person has got a urinary tract infection? No. But it is one of the key things you need to look for in your urinalysis. But leukocytes can be associated with almost anything that causes inflammation along the urinary tract. The other thing that we're looking for that is actually quite specific for urinary tract infections is nitrites. So we've made a diagnosis of most of the urinary tract infections just from those two investigations, just two findings on a simple investigation. Another thing, and that can lead on to people having recurrent urinary tract infections or incompletely urinary tract infections, is then guesswork and us pulling out our favorite antibiotics. We need to make sure that we send these samples to the laboratory and that we discuss them with the microbiologist, even if we do give preemptive treatment. Because we need to know the precise bugs. I've told you the most common infections, but which you can start your treatment with, but make sure before you send start the treatment that you've sent the sample to the laboratory so that you can confirm and make sure you're not causing antibiotic resistance or making that poor woman more ill and leading on to pyelonephritis. Now I'm going to come on to another little aspect here. Once you've treated your infection, or you think you've treated it, you haven't completed the deal until she completes her antibiotics and you send a sample off and you make sure it's clear. Because some women need more than the typical 3 days, 5 days, or 1 week treatment. So you need to make sure you get a test of cure once you treat the infection. Now,
Joyce, sorry,
last,
Joyce,
yes,
Joyce, sorry. Hi, Joyce. Can I jump in
yes,
here?
hi.
I'm so sorry. The time for the presentation is up to 2:30, and the next speaker has to leave at 3 o'clock at the end of their presentation. So
Oh,
I'm so
okay,
sorry. We'll have to move into the next presentation
okay,
in order to facilitate them as well. But you have your
okay.
presentation, don't you, Joyce?
I do,
You
I
have your
do, I do.
and the attendees will have access to your presentation and this video recording within about 3 days of this day. But if you
Okay,
if you wouldn't mind perhaps overlaying the rest of the presentation that you've got outstanding with audio, then that would be
okay.
amazing. Then we'll be able to hear all of the rest of the presentation. Would that be okay?
No, that's fine. And no, thank you very much. So the other aspect I wanted to touch on was the treatment and the choices of antibiotics, but we'll send that on. And thank you very much,
Yeah.
everyone, for your time. That's
Thanks, Joyce. Lovely to see you again.
okay. And you too.
Thanks.
Goodbye now.